It's a real pleasure to be able to be with you tonight, with you Lenappers. And if you will look on the right, you will see a picture of the two of us that are doing it. I'm P.D. Miller on the left, and that's Bob Levine of Philadelphia on the right. First of all, I'd like to thank the Greggs for Bob and Dawn for their insight and vision in allowing us to present this webinar, because this is on the use of the MMPPI in clinical practice, the benefits in long-term periodontal and systemic health. The MMPPI stands for the Miller-McIntyre Periodontal Prognostic Index. This is an evidence-based study. It is quantitative. It has been tested for many years, and it fits hand in glove with what you Lenappers are doing. Because let's face it, more so than any other discipline in dentistry, I think you Lenappers are doing more to save teeth than anybody else. And what we will show you today is going to even strengthen that. For as Dr. Levine and I think, the Lenap concept as well as the MMPPI fit together like a hand in a glove. So hopefully you will find this as beneficial as we hope that it is going to be for you. So the Lenap webinar. First of all, we're going to start talking about the MMPPI, or the Miller-McIntyre Periodontal Prognostic Index. And Dr. Levine, who is in clinical practice and using Lenap as well as implementing this process into his practice several years ago, is going to be talking about how he is using it, and I'll be talking about, in theory, what you need to know about. First of all, this index is used to determine the long-term prognosis on periodontally involved molars. That's what the study was. The study was published in the Journal of Periodontology in 2014 in February. However, it can be used on single-rooted teeth as well, and single-rooted teeth, as you already know, have a much better prognosis because they don't have furcation involvements and they don't have the molar type, which is one of the 7 factors involved in this concept. What do you say when a patient asks, if I have this periodontal treatment done, how long can I expect to keep my teeth? Well, the answer is very nebulous. Well, it all depends on this, it all depends on that. What if you presented a case to a patient and they said, how much is this going to cost? And you said, it all depends. It depends on this and depends on that. What is the likelihood of the patient accepting treatment? They don't have enough details. The beautiful part of this has a very precise percentage that you can share with the patient, and the patient will understand exactly what we're trying to do. Now, very importantly, the MMPPI, and this is what we have branded the index, and I will use that term throughout the rest of this webinar. It's evidence-based, it's statistically validated, it's accurate, it's been published, and very importantly, it received the Clinical Research Award from the Journal of Periodontology in 2015. And on the right, you can see my pretty face there holding the diploma, or the whatever that's called there, and you can see on the letter on the left where I received the letter. Now let me emphasize what this is. Every year, the American Academy of Periodontology reviews all the literature of clinical significance and selects only one article to receive the Clinical Research Award of the year. So this is like having the J.D. Powers Award on that. This is very significant, and we are very proud that it got it, but it also allows us to do this. All right. Now, where did we derive the information? This is information that was derived from a complete periodontal examination and case history on patients that I saw in my practice over a 40-year period. The study took place, it's a retrospective study, and it was done between 1969 and 1994. It ended in 1994 because every patient had to be in the study at least 15 years. And if you review the literature, and Dr. Levine will comment on that, there's no other study in the literature that goes out as long as this. The Hirschfeld-Washman study is 22 years. It had healthy teeth and unhealthy teeth. It had single-rooted teeth and molars. This study was out 24 years, and it just dealt with diseased molars. All right. The inclusion criteria eliminated the vast number of patients. And here are the inclusion criteria. All the patients had to have moderate to severe periodontitis. Now let's think about the time, 1969 to 1994. Implants had not come on the scene to that level, and I was a pure periodontist. And let's think about it. Is any referring dentist going to send me a patient that doesn't have severe disease? I didn't get a gingivitis case. So it was self-fulfilling that I was seeing cases with moderate to severe chronic periodontitis. But here's the one that got us. All the patients had to have all 8 of their first and second molars present so that we could evaluate them. And I went through probably 1,000 recall patients to find patients that had all 8 of their first and second molars when they came into the practice. And the average patient coming into the practice was 42 years old. So someone with moderate to severe chronic periodontitis who's 42 years old, 90% of them had already lost one molar. I ended up finding 106 patients that met this criteria, but the data was insignificant on 4 of them, so the data is based on 102 patients or 816 molars. And as I said earlier, all of them had to be a minimum of 15 years post-treatment. So this is a long-term study. So the years post-treatment, the minimum was 15 years, but get this number right here. The average patient, when we stopped analyzing this, had been in the practice almost 25 years. And Bob, I cannot think of another study that goes out 25 years. And the range, as I pointed out, was from 15 to 40 years from the time that I went in, that I started the practice. All right, here are the 7 factors that make up the index: age, diabetes, smoking, molar type, probing depth, furcation involvement, and mobility. Interestingly enough, the lower the number, the least significant is. And what do you see on age? 0 to 30 is a 0, and we score a 1 if they're over 40. Now, that doesn't make a lot of sense when you first look at it, because what happens when you treat a 22-year-old patient with 8 and 9 millimeter pockets and a couple of furcation? Most dentists, not you nappers, would figure, that has a poor prognosis. I'll just treat them with root planing and curettage. Well, that's not going to get the junk off the roots. The patient is going to proceed, and it's a self-fulfilling prophecy the patient's going to lose the teeth. So therefore, if we will treat these young people in depth just as you nappers do, you can find these patients can have a great prognosis. The next category, diabetes, and you can see that this was based on A1C scores, and I'm going to discuss that in just a minute. You're also going to find that smoking of these factors had the biggest impact on prognosis, and that's why if a patient is a non-smoker, they score a 0. If they're a smoker, they score a 1. They score a 4. So therefore, we're going to talk about smoking in a minute. Molar type. Originally, molar type was not in the study, but when they analyzed the data, as you would expect, the most susceptible tooth being lost was a maxillary second molar. So therefore, the statistician said that I needed to have a factor for that. We all know that mandibular molars have a much better prognosis than maxillary molars. We know the maxillary first molar has a better prognosis than the second molar. So I submitted these factors here: 0 or a dash on a mandibular molar, a 1 on the maxillary first molar, and a 2 on the maxillary second molar. And the statistician validated this, so now we have an accurate score on molars. Probing depth. Now let's think back to 1969. We did not use the term clinical attachment loss. This was a retrospective study, not planned to be published or anything. And when I did an examination, I just indicated to the dental assistant who was recording the data, If I had a furcation involvement, to check, yes, that was a furcation involvement. So this has nothing to do with the class of a furcation, class 1, class 2, class 3. It's simply the number of furcations involved. Now, if we were going to do a progressive study, certainly we would use clinical attachment loss, but this is one of the flaws of doing a retrospective study. Furcation involvement. Oh, I skipped. Okay, furcation involvement. I've already discussed that in some depth. Excuse me, Bob. We'll move right on that. And we found, as you're going to see in a few minutes, of all the factors involved, age, molar type, and furcation had the least impact on long-term prognosis. So you nappers need to think through this, and more importantly, the average periodontist or dentist needs to not use furcation involvement as a criteria for extracting a tooth. For you're going to see in this study that furcations have a good prognosis if they are treated, but what most people do say, oh, that's got a furcation involvement, that needs to come out because it has a poor prognosis. Not so. Don't be fooled by that. And mobility. We're going to go a little bit in depth. I'll talk some about that. Bob will talk some about that, because it's a very simple way of accurately determining mobility from a clinical standpoint. So there are the 7 factors that are involved. Now, diabetes mellitus as a prognostic factor. This will come as some surprise to you, because only 2 of the 102 patients presented with a diagnosis of diabetes mellitus. I would have thought that would have been much higher. So therefore, with only 2 patients having that, obviously there was no way that I could come up with a statistically validated factor for that. Because of that, I went to the textbook that you see below and determined that we would use varying levels of the A1C level to determine a score. And here are the scores we came up with. If it's less than 6, that was a 0. And when you score, we have found in scoring on the sheet that Bob is going to discuss with you, we simply put a dash for that because you tend to try to add in a 0. 6.1 to 7, we assigned a score of a 1, 7.1 to 8, a score of a 2, 8.1 to a 9.0, a 3, and over 9, a 4. Because when you get levels in the 8 and 9 scoring level, you'll find the patients, this is where patients begin to have the retinal changes and the eye changes and so forth and so on. And below you see a study that is going to be published. It's already been accepted for publication by my colleague, Dr. Gopal in India, who has been an integral part of the development of this concept since the inception. And he has now done a study and has affirmed or confirmed, whichever you prefer, that these are statistically validated scores. So thank you, Dr. Gopal, for your research on that. Now, what do you do when the patient comes in and they don't know their A1C score? Well, you can't score the patient, so therefore you can't give a score on that. You have to send them to a physician to get that. It may be 6 weeks before they get back, and the patient loses interest. So therefore, you can go in there and use a score of a 2 arbitrarily until you can get an accurate A1C score. But here's something I think everybody on this call ought to look into. There's an in-office testing kit available. It's called the A1C Now, and you can see the cost of that if you buy it in a set of 20, costs you about $15. And let's face it, if you're doing a big case and you want to get started with it, you want to know what the prognosis is and so forth, go ahead and do the A1C in the office. But let me give you a word of caution on this. Diabetes mellitus is a medical diagnosis, and when you label a patient a diabetic, they may have a job that they cannot do if they are diabetic. And I'm thinking about someone working on the scaffolding on the skyscraper or stuff. So the proper thing to do is if you get an elevated A1C, yes, the patient's probably diabetic or certainly a diabetic, and you simply tell them you've got an elevated blood sugar, you need to check with your physician on that. And so that is a precautionary situation which I think you need to take into consideration. And I've been a diabetic since 1991, and this is the A1C score that I had a couple of months ago, a 7.1, and my endocrinologist wants me to keep it under a 7, but having had diabetes for 30 years and being 80 years old, she's really not disturbed about me being a 7.1. But this just shows how it can be done. And certainly this dental assistant or a hygienist can administer this test. And we're going to talk about later how the MMPPI has such a positive effect on the morale and in the office. Now, the significance of smoking. If you learn nothing else from this webinar, learn this. You have two patients that smoke. They have, you got two patients with the same level of disease. One smokes and one does not. The smoker has a 246% greater chance statistically of losing their teeth. And when you share this with patients, they're aware that smoking causes lung problems and causes this, but they are not aware that smoking can have such a negative impact on their periodontal health. And often this can be the straw that breaks the camel's back. And on my web textbook, which you saw on the first slide, www.pdmillers.webtextbook.com, there's a video on there on smoking cessation. It's a little bit corny, but it is impactful on patients, and I would urge you to look at that. It is it's an actual case that I counseled on, but the individual is an actor doing that, a fellow dentist who's a non-smoker. And what we did on that, we made one run on that, and I want you to look at the expression on his face when we talk about the impact of smoking cessation. Now, I think we as a healthcare professional, if a patient is smoking, has both a moral and ethical obligation to do some level of smoking counseling. And that's entirely up to you and to your staff. But if you don't want to get significantly involved in that, you can urge the patient to call 1-800-QUIT-NOW, where they can talk to someone 24/7, 365 days, and they can give the smoking counseling. Personally, I'm so impacted by this. If I were in practice, I would incorporate that in my practice. Now, here's an interesting finding. We've already discussed this to some extent. When the extraction data were analyzed, 34.63% of all the molars lost were maxillary second molars. Duh. Everybody listening to this webinar is well aware that the most susceptible tooth in the mouth is the maxillary second molar. An aside on this, there's a study out there, and I wish I could find it. It was back when I was in my residency back in the 60s, which found that you did 60% of your chewing with the first molar, 10% with the second premolar, 10% with the first premolar, and only 20% with the second molar. So therefore, scoring especially a first molar that's very compromised and attempting to maintain a first molar occlusion means the patient is going to have 80% function on that. But when this figure came out, the statistician said, Dr. Miller, this is statistically significant. You've got to come up with some scoring factor on that. And even though the mandibular molar has a through-and-through frication, you have two frications on the lower molar, but if you have a through-and-through, I consider that a 3 because I think that is a graver finding, as it were. So the scores for molar type are mandibular molar 0, maxillary molar a 1, first molar, maxillary second molar a 2. But how long do teeth with frication involvement survive with treatment? And here's a study done, a colleague of Dr. Levine's, that found that frication-involved teeth, if they are treated and treated in depth, have as good a prognosis as some implants on that. So I think you should note that as well. Now, let's take a little time because Dr. Levine thinks that this is something that's very important as well as I do. Now, when you do mobility on a patient, Does it move a half a millimeter, a quarter millimeter? Is it depressible in the socket? It means different things to different people. But here is a very clinically valid way of evaluating mobility. Let's face it, lower incisors are short-rooted teeth, and in the healthy mouth you can move those a little bit, and you're not concerned about that. But a Class 1 mobile tooth means that the tooth is slightly mobile, but you're not concerned about the prognosis. Simple enough. Class 2 mobility means you are concerned about the mobility. Now let's look at Class 1 and Class 2 on a particular case. You've got a 29-year-old who's going to have a bilateral free end saddle partial made, and you're going to clasp the second premolars. All right, the patient's 29, going to have a bilateral free end saddle partial, and those bicuspids are a little loose. Are you going to be concerned about that? Obvious you are. So you would score those a 2. Now let's look at me, 80 years old, with all my teeth, and my lower second premolars can be moved exactly the same amount as those premolars on the 29-year-old. But I would not be concerned about mobility, so I would score that a 1. But it has a clinical meaning, especially if the patient is transferred to another dentist. They know exactly what the treating dentist that made the referral was talking about. And most of us think that a Class 3 mobility is a condemning mobility. But what about the case with a significant gingivitis that has been through orthodontic treatment and has had significant root resorption and the teeth are quite loose? Class 3 mobility. Are you going to extract those teeth because they have some mobility on them? But by treating and reducing the inflammation and perhaps doing some occlusal adjustment therapy, those teeth could tighten up. So let's not consider that a Class 3 mobility is necessarily a killing mobility. Now let's get a little scientific on this, and bear with me as we talk a little bit about the statistics. We use the multivariable Cox proportional ratio on that, and you can see this is taken from the table in the article that I mentioned, published in the February issue of the Journal of Periodontology. But here's what's significant. Look at what the scoring is on this particular column. You see age, molar type, and furcation all have scores in the 1.2 range. What does that mean? That means that those are not particularly significant. So for the first time, we have scientific evidence, statistically validated data that furcations are really not that significant. But let's look in red up there. There is the number on smoking, and you see it's a 3.46. So I used a score of 4 on that, and the statistician evaluated that and said that that was statistically validated. And later, Dr. Gopal, who did the study on diabetes, a progressive study, which is now about 4 years old, found out that this was a statistically validated score. And he used 25 patients. And using the data that I supplied to him, the little video on smoking cessation, and showing the patient that they had a 246% greater chance, I think it was 22 out of 24 patients either stopped smoking or significantly cut back. Now, some of you are thinking at this point, well, what about bacterial plaque and what about home care? Why was that not included as a factor on this? Because there was no simple way to score that in a private practice situation without taking an inordinate amount of time, in my opinion. So therefore, a patient would come in, and depending on what was going on in their life on recall, one recall appointment they'd be cleaning very well, the next appointment they wouldn't be cleaning at all. And more of this had more to do with things going on in their life than changes in oral hygiene. So perhaps that's one of the flaws in a retrospective study. Now, advantages of this Cox ratio. Now, what we did on this, if we'd used a relative risk ratio, I think we would have eliminated 175 teeth. Because with the relative risk ratio, any tooth that's lost before the end of the study is necessarily deleted from your base. So we would have eliminate 175 teeth. But by using this ratio, we had 641 molars that survived, nearly 80%. So the question you're asking yourself now, well, I bet Petey was saving a lot of teeth that damn well need to be extracted. So my answer to that comes from the American Academy of Periodontology, who had this position paper that they had in 2009, I believe it was, 2011, excuse me. And what is survival versus survival in health? Survival in health is classified as no redness, no suppuration, and no bleeding on probing. And of the teeth that we treated on that, 87% met the American Academy of Periodontology criteria for surviving in health. Now, I'm not going to sit here and tell you that all these patients had ideal probing depth, but I think we need to think in terms of perhaps converting a periodontal pocket into a periodontal defect. And maybe we're too hung up on numbers, because if you have no redness, no suppuration, and no bleeding on probing for many, many years, and you've got crestal density and you're not losing any attachment, I think that's a reasonable result. And I think those seasoned periodontists and dentists who've been practicing for many years will totally agree with that. So a little bit of science here. Each of these represents a number. The green at the top means you have a score of a 1. The blue on the bottom means you have a score of 15. And each of the little dots on that represents an extraction. So how did we come up with the percentages? On the vertical axis, we drew a line and then went over the vertical axis and we saw a percent. So if a patient scores a 1, that's 98%. If they score a 4, it's 95%. And I'll tell you this, of the teeth that survived, the average score on those was a 4.63. So the object of treatment is to keep the score below a 4, below a 5. And we have a little ditty that Bob and I use, kind of corny, but it means something to the patient. If you want to keep your teeth alive, keep your MMPPI below a 5. So there is the score on that side. Now, this is a score sheet. It varies. I've got about 6 of these. This is about the 6th edition. Bob has one that varies a little bit different from this. But if you go to my web textbook, P.D. Miller's web textbook, there's a link on resources. And I have got this score sheet on there. Now, if you look on the lower right where it says keys to success, these are very, very important because they need to be shared with the patient. Now, if we treat teeth for many, many years, in this case 24 years, some retreatment is going to be necessary. And this is sort of like being in warranty and letting the patient know. And Fardall published this study, and what they found in this study, come on, click, baby. All right. Some type of retreatment is going to be needed to be done about every 6.7 years. The type of retreatment, 60% will require non-surgical therapy, 40% will require additional surgery. Now, that's with conventional treatment, but what are you Lanappers going to do? You're going to just do some localized Lanap. So you may want to share this with the patient because it's not a guarantee that we're going to have a result, because this is extremely important, the keys to success. And what I want you to do in looking at this is I want you to note that none of these are under the control of the dentist, because the patient has to brush and clean interdentally on a daily basis. Second, they got to clean the posterior 1/3 of the tongue, because after you do interdental cleaning and a great job of brushing, 90% of the bacteria left in the mouth are on the posterior 1/3 of the tongue. And trying to get a wet toothbrush back there, first of all, it'll gag you, and if you brush back there, it just smears the bacteria around. You need to have a metal scraper to scrape that debris off, and that's the responsibility of the patient. The patient has to adhere to the recommended maintenance schedule. they've got to have the treatment that we recommend. And if they have an elevated blood sugar, they need to lower that. If they're a smoker, they need to cut back markedly or preferably stop. So all of these things are under the control of the patient. And if you treat the patient and they do these things, you're going to have the result that we see on the score sheet. So here are the conclusions before I turn it over to Bob. Young patients with moderate to severe disease can have an excellent prognosis if they are treated in depth, if they are LANAP. Smoking is the most significant factor in determining periodontal prognosis, and let that 246% figure soak into your brain. And as I pointed out, rethink furcation involvement as a significant prognostic factor. For if these furcations are maintained, perhaps with a water irrigator using a sodium hypochlorite rinse in that, I have found the furcations in this study could be maintained for years and years and years and years. So here is an example of a case that I'm not going to go into at this point because I'll take a brief if I've got time, Bob, if I may. This is a 29-year-old girl, and the diagnosis on her is a very severe gingivitis, no attachment loss. So you can see that she scores an 11, even though she has a gingivitis, which means in 15 years, the chances of losing a teeth is probably at least one or two teeth is 50%. But if you look on the right where we scored number 14, if she stops smoking and we get the pockets eliminated, get her on good home care, get her diabetes better controlled on that, she's a 3. And therefore, she has a 96% chance of keeping the teeth for 15 years. So you can see how impactful this can be on lifestyle change. And I think the difference between the physician and the dentist is narrowing very much because with the systemic factors we talk about, the systemic rinse, and adding this study to it, I think we can have a marked impact. And I would urge you to sit down and go to the various videos I have on my web textbook. There's one on how this was derived and controlled. I've given you an overview of that, but you need to look at that. You need to look at clinical scoring. You need to look at the smoking video. And in my opinion, and Bob can mention this if he wants to, I think this needs to be staff-driven. The staff needs to do the scoring on this, and they need to take ownership of this. And if they do, it's very easily incorporated into practice because it's their idea. It also is a morale builder. It also elevates them in the eyes of the patients and their job responsibility. So there are many, many goods. So at this point, I'm going to shut up and let my colleague Bob take over and elaborate on as many of these factors and cases that he would like to. Bob, it's all yours.
Thank you very much, PD. I personally want to thank you for all you've done in dentistry for the benefits of all our patients. There isn't a day that goes by that we don't think of you, PD. Your Miller's recession classification of 1 through 4 we use every day as periodontal plastic surgeons, as well as the MMPPI. So thanks again. Sal Mary's a good friend of ours from the University of Illinois in Chicago, has a textbook coming out in 2019, Advances in Periodontal Surgery, a clinical guide to techniques and interdisciplinary approaches. He's asked us to do a chapter, and it's basically the title of today's presentation. One of our conclusions, the routine use of the MMPPI should become the standard of care, especially for patients who present with numerous risk factors to long-term success. And this is all talked about in the MMPPI. It has helped significantly to improve case acceptance, follow-up care for surgical procedures, including root coverage, LANAP, as well as LAPIP. So how do we use it in practice? This is a welcome letter that we give to the patient at the initial visit. As a periodontist, I'll see the patient initially, not my hygienist or my dental assistant, but we'll see the patient. So as part of my initial exam for all patients, we give them this welcome letter and do the MMPPI, and you'll see why. So both of these will go to the patient. Welcome to our practice. As part of our comprehensive examination, we are providing you with a score that predicts the outcome of your periodontal treatment and what must you do to achieve and maintain this level of success long term. And this, again, is the keys to success. The science supporting this research was published in the journal Periodontology, as PD mentioned, in 2014, and won the prestigious Clinical Research Award in 2015. And we will talk about all these factors again and then relate to cases in my practice. What makes it unique? It's the only index that is quantitative, the only one that determines the prognosis at the initial exam. As PD mentioned, the average was about 24.2 years and went from 15 to over 40 years. Teeth removed during the maintenance phase survived at least 15 years before being extracted. So we only need to know the one molar to get started, to get the desired motivational impact. So when I sit the patient down looking at x-rays, checking them clinically, what I'm thinking of first is which molar are we going to score. We always try to give the patient the worst case scenario. So I'm looking for usually a maxillary second molar or a maxillary first molar. But sometimes the patient presents with no upper molar, so we'll go to a mandibular molar. So we score the most severely involved molar you want to keep. With a little practice, we can do this mentally with minimal or no chair. And in our maintenance phase, we have our dental hygienists do that, and we'll go through that as well. So the whole mouth is reflecting off of one molar. This is a difficult concept for some, but just think it's one molar, the worst molar you plan to keep, and that's going to reflect the score. And we make the analogy, it's similar to the score that they will get, patients will get at their physician for their blood pressure or their cholesterol or the hemoglobin A1C. So there's 5 cases we're going to look at from my practice. Case 1 is Amy. We scored tooth number 3. Case number 2 is Stephen. With multiple molarifications, we scored tooth number 3. And we'll talk about his lower left, which had through and through furcations, possibility of root caries. Case number 3 is Will, missing all his upper teeth. So we scored tooth number 30. There'll be some teeth extracted, but we're keeping number 30. Case number 4 is Mike. We scored number 30 also. Number 3 was depressible, a 3 mobility, which we termed hopeless, but we still have that in his mouth, and you'll hear about Michael later. And number 5 is Mindy, who we scored tooth number 15. We could also apply the MMPPI to single-rooted teeth as well as molars. So again, the 7 factors, my MMPPI scoring that we use in our office with my partner Phil Fava is slightly different, but it's basically the same as Dr. Miller's. However, we just have the sequence of the 7 factors slightly different. So there's 4 marking periods. So I like to call this the perio report card, similar to somebody in school, where they'll be graded in 4 separate marking periods. So we call that the perio report card. Our target goal, again, is less than 5. And this is very important that this is something we share at the initial visit of the target goal of being less than 5. This is our goal for treatment. And many of our healthy patients are less than 5. So this is some very good news we could share with patients at the initial visit. So again, there's Dr. Miller's ditty. If you want to keep your teeth alive, keep your MMPPI score below a 5. And as you can see, guarded, good, and excellent, less than 5 has an excellent long-term prognosis for 15 and 30 years. We are clinicians, not magicians. This is something that I speak about with patients on a frequent basis. As all of us know, patients sometimes come with expectations that are off the charts. So we get them in line by saying we are clinicians, we are not magicians. And in this case, for the MMPPI, the keys to success are so critical. They're all in their hands, as PD had reviewed, and we'll speak more about this as well. The tongue sweeper is the one that we recommend right here. It's stainless steel. I personally use this. PD uses this. You can order it from Robert Rippich in Ohio, and you can get it at tonguesweeper.com. Stainless steel goes in your dishwasher. 2/3 of the bacteria we're really trying to remove, or 90% of them, are on the posterior 2/3 of the tongue, so they need to be scraped off. And it's actually very comfortable to use, unlike just using a toothbrush, which just pushes the bacteria around. So there's a strong motivational effect when we use this at the initial visit with a target score of less than 5. We use it for all maintenance visits with patients. So depending on what type of practice you're in, the dental assistant may be doing it, or the hygienist may be doing it as in our practice. And we use this including in our well-maintained patients. It gives them really value as to why they're coming in every 3 months and the periodontal health is healthy, and it keeps them maintained. So the keys to success is adhere to the recommended maintenance frequency, and this reinforces that the frequency that they're in is working. So patients are also more likely to invest in comprehensive care, such as aesthetic or implant rehabilitations and other forms of periodontal therapy based on improved prognosis. So our plaque control protocol with LANAP and LAPIP patients, we do the Jan-Lindy protocol of every 2 to 3 weeks with plaque control reinforcement for 3 months, and then they go into the maintenance phase. And we do a prophy, and at each visit, this is critical. We have the articulating paper out, and we check for any discrepancies, any working, non-working, or protrusive interferences, and we're constantly adjusting the occlusion because they will change. The occlusion is not stable. It's very variable, and it can change from visit to visit, especially if the teeth are mobile to begin with. We have them rinsed with antioxidant, non-alcohol mouthwashes such as Closis and Perisciences. I'm concerned about a very large number of my patients have medication-induced xerostomia, MIX as we call it, and we want to avoid any alcohol products in mouthwashes. We also have them rinse and irrigate 1/2 to 1 teaspoon of sodium hypochlorite in warm water, 6 to 8 ounces. And this is what we use in our office, and it explains everything. So just take a look at this. We don't have to read this, but this is how we give it to our patients, and we use it for all our dental implant, our hybrid for large cases, and our LANAP cases as well. So we prefer the patients to use this depending on the severity, but generally 2 to 3 times a week or more. I mentioned medication-induced xerostomia. This is Stephen, and we're concerned about patients like Stephen who are on multiple medications. We have an aging population, and we're concerned about future tooth loss. Stevie mentioned we are the physicians of the mouth, so this is a discussion I have every single day. Physicians do not talk about MIX with their patients. They talk about nothing regarding their mouth, generally speaking. And this helps also with compliance to maintenance visits. So when we go over to the right, again, our target goal is less than 5. So statistically, and I reviewed this with the patient that had MIX, you should never lose a tooth to periodontal disease. I understand. I underline periodontal. However, as you mentioned right below, I've written, but we have concerns with dental caries because of the MIX. So this will motivate them to complete treatment, stay in maintenance, and frequently I will increase the maintenance frequency with either us and or the restorative dentist, so it becomes really a health benefit to the patient. So summary, the benefits to the patient, better understanding of their long-term prognosis with our target goal being less than 5. It encourages lifestyle changes to improve their overall health, which again, all the keys to success are all within their hands. Nice thing about the LANAP protocol, it can hit our target goal quicker in 1 visit and with little to no discomfort, as the studies have shown. And we looked at our first 75 patients in our practice and saw that 90% of our first 75 LANAP and LAPIP cases had between a 0 and a 1 discomfort, so 0, 1 pain out of 10. So what are the benefits to the dental profession? It's a strong motivational effect on case acceptance, post-treatment compliance, smoking cessation, knowledge of the MIX, because that's important to review with our patients, as well as the A1C control. We're positioned as the physicians of the mouth, and that's a term I use with patients. We're translating clinical outcomes into patient value. So the MMPPI is something they could grab onto, they could understand easily, and it leads to increased patient acceptance to treatment, which in our case, we're talking about the LANAP protocol. We published on this back in 1995 as part of an evidence-based group of 4 task forces, and we presented on this exact topic with GTR and GBR. And this is an interesting article to read through. You could put LANAP in its place. How do we talk to patients, and how do they understand value of what we're suggesting that they go through and follow through? And as PD mentioned earlier, we give them a precise percentage that patients will understand as to their prognosis. It only takes a few minutes to do. We can do that in our minds frequently. Increase referrals. It empowers our team members. So we have our dental assistants, we have the dental hygiene team, as well as our case presenters in our office presenting this data. And again, it empowers our whole team. Leads to increased acceptance for restorative therapy because they're not getting bogged down in periodontal therapy, as we see when we're doing full mouth surgical treatment. The LANAP protocol has really changed the game in my office for the past number of years as to how we're getting patients healthier quicker and back to the restorative dentist. It also plants the seed for future retreatment. So let's look at these 5 cases. Again, the first thing we're looking at is which molar are we going to use as the MMPPI scored tooth. This is Amy. She's healthy periodontally. She comes in for a root coverage procedure, 24 and 25, through a traditional referral model. Number 24 recorded a Miller type 2, and number 25 a Miller type 1 recession. This is chapter 1 in our textbook with Sal Neri, the executive editor. So we looked at her MMPPI, and it comes up as a 3. Molar type we used was a maxillary first molar, and we used tooth number 3, and it scored a total of 1. So the prognosis right off the bat is extremely high. The interesting thing about Amy, and this is from her perspective, and she just did a video for us actually last week discussing the MMPPI. So after I reviewed her score of 1, knee to knee, eye to eye, as we do with all our patient consultations, Amy shared this with me, which was very interesting. Quote, my gum recession was the beginning of a cascading downhill course from a dental standpoint. So she felt because of the gum recession locally that she was going to start losing more teeth. So this score of a 1 really reinforced in her mind that to go through this treatment and to keep with her restorative dentist at the recommended maintenance frequency of 2 to 3 times a year, she had extremely high chance, over 95%, that she's going to keep her teeth for 15 years. So for Amy, very highly motivating. She leaves the initial visit with a very positive news regarding her periodontal health and her periodontal prognosis for 15 years and 30 years. Reinforces her restorative dentist referral for the tissue grafting. Of course, we said that it's needed in this area because of the clinical appearance. Motivates her to complete our treatment plan, and we reinforce the importance of maintenance care with the general dentist, which is a win-win-win. Going back to the root exposure here, she's healthy today, but in 30 years, she may be on many different types of medication that could be causing MIX. The root coverage procedure will prevent any root caries if we're able to get 100% root coverage, which we have a high chance of doing with a Miller type 1 and type 2. So we do the tunnel procedure. We're using a palatal subepithelial connected tissue graft, MDSc, PRGF, and a coronally positioned flap. We use a laser also for the laser hemostasis on the palate, so we use that in all our cases. And at 3 months, we see an excellent healing. Tissues look great. We've got excellent root coverage, and the patient is extremely pleased with the result. Case report number 2, Stephen, comes off the internet, presented over 4 years ago. And as we look, we're going to score tooth number 3. Tooth number 3, as you could see, has furcation invasion. He's a 66-year-old non-smoker, full mouth perio surgery history 12 years prior, which was very uncomfortable for him. Number of illnesses, and he has a dry mouth because of the medications, the MIX. His compliance has been excellent. He's been every 3 months. Medical summary ASA 3. So why didn't we score tooth number, say, 18 and 19? Off the bat, we said these teeth I'm concerned about with the MIX. I think that the possibility of root caries in the furcation of 19. So I said, we're going to just leave that alone. We're going to treat that, but we're not going to score this site, even though this had the deepest probing depths of greater than 10 millimeters in the furcation area, but we're going to go and score tooth number 3. So Stephen comes to me off the internet because he had full mouth periodontal surgery. It was painful and was told recently by his dentist that he needed it again. He typed in on the internet, Lanap, somehow he had heard about it, did his research, and said, I want this procedure. You can see his video, I'll go back a second, on our website at PADentalImplants.com. I love this quote by PD. Teeth are not lost to periodontal disease, they are lost to titanium. As many of our dental colleagues would be suggesting extractions and implants in all four posterior quadrants. So right at the initial visit, I'm planting the seed for the possible future failure due to MIX and root caries of 18 and 19. We're not extracting these teeth, they're symptomless. There's one mobility on 18, but the probing depth mid-buccal of number 19 is over 10, and generally they're 8 to 9 and 10 millimeter probing depths in that quadrant around those two molars. We're going to score number 3. It has a 2 mobility, and you'll see what the MMPPI comes up to. So the initial MMPPI with Stephen was an 8, and as we looked, furcation, he had a single furcation in mesial, buccal, and distal. Again, we're not looking at class 2 furcations. They were all just noted as a furcation. So there's 3 furcations, so it's a 3. He knew his hemoglobin A1C, and it was less than a 6. Mobility was a 2. And again, with the Lanap protocol, we're doing significant occlusal adjustment on these teeth. Probing depth was a 1, so that ranged between a 5 and a 7. Molar type, I'm actually first molar, we're again scoring tooth number 3, and he's a non-smoker. So we discussed from the start that he had a 15-year prognosis of 81, and looking at it based on being scored as an 8. So for those who do Lanap, we could see exactly this is what it looks like after the hemostasis. We've done significant root planing, significant occlusal adjustment, and this is what it looks like after the hemostasis. We take x-rays immediately post-surgery. Again, we scored tooth number 3. The seed has been planted for future failure of both 18 and 19 in retreatment. And I like the term, this is an equivalent, and this is how I discuss it with patients, equivalent to a periodontal Hail Mary. We're going to save these teeth in the lower left. The patient knows, Stephen knows, that these teeth may need to be retreated or extracted or whatever other treatment we could think of. But as a Lanap clinician, I'm thinking first Lanap in this area, as long as he does not develop any type of root sensitivity because of caries. So 2 days post Lanap, there's a 0 out of 10 pain. So he's one of our 90% of our patients that have 0 or 1 out of 10 with full mouth Lanap. 7 days, we could see how things are healing. That membranous, grayish membranous material is gone, except for certain site-specific areas. The tissue is already looking pinker. At 2.5 years, at each maintenance visit, we discuss his MMPPI. Using tooth number 3 again, we're going to use that at each visit. Again, also reinforcing and mentioning our concerns with both 18 and 19. This is how we use it in our office. We have it encased in a plastic laminate with an erasable marker. This is how we use it in our maintenance system. These are our 3 hygienists, Barbie, Maggie, and Tanya. And the patients, we give copies initially of this on paper, and we could also scan this and send copies to the patient as well. So they have that in their possession. And we review that chair side, and it only takes a couple minutes. At 2.5 years, again, looking at the lower left, we have improvement, but the seed has been planted to retreat. We're down to 6 and 7 millimeter probing depths there. He does feel bleeding. He does notice that when he's flossing and irrigating, but the upper right has significantly improved. And that's the tooth. We're scoring tooth number 3. And you can see he went from a 7 to a 6 to a 5. So if I was a teacher, I'd be scoring Stephen an A+ as he's improved in 3 consecutive marking periods. So the prognosis is now up to 93% because he's got the magic number of 5. It'd be nice to get a little lower, but we still have 2 furcations on that tooth number 3, which is the scoring tooth. We got the mobility down to 0. Again, we're occlusally adjusting and really checking his contacts at each visit. And the probing depths have decreased, although it's still a 1. We can change the molar. We cannot change their age. At 3.5 years, Stephen comes in on maintenance. This is Bob. I'm ready to retreat my lower left molars. And what do? As a Lanap clinician, we're using Lenap in this area, LAPT in the lower left. And at 4 weeks, he's looking significantly better and actually feels better also in this area. He's noticed that clinically himself. As PD's mentioned, furcation involvement shouldn't be used as a significant factor when deciding whether or not to extract the tooth. As you can see with Stephen, 2.5 years later, he has all of his molars. This is Will. He comes off the internet because he had all his upper teeth removed. There's still sutures, black sutures you can see. And there was no treatment plan as to tooth replacement. And the next visit was to extract all his remaining teeth. He's 32 years old. He quit smoking 2 years prior, but he does have a history of generalized aggressive periodontitis. He's not on any medications. His compliance was poor to prevention, so this is something we need to really review with Will. Just had his first child, and as many of us know, our patients really change when they know they've got another mouth to feed and want to be around for their grandchildren, as I have 2 recently born grandchildren myself. Medically, he was an ASA 1. So we're going to score tooth number 30. We're planning on extracting number 18, which are root tips, and 29 and 32, which are also root tips and severely decayed. So to place or not to place implants, when is the question? As PD mentioned about a 32-year-old young patient in his practice, we're going to treat them, and the Lenap procedure really is treating them decisively in these areas. Again, he quit smoking, but the concern is with the generalized aggressive periodontitis, and we know what factors contribute to success and longevity of implant restorations. They're systemic, which we've noted most of these already. There's local, including as periodontists. We need to look at keratinized mucosa thickness and width, and social, and these are what are in the patient's hands. Oral hygiene, stress and power function, their maintenance. These are the keys to success. And Delago published in 2017 the peri-implantitis rate in patients, as well as on implants specifically. The risk factors, as noted, cement is a big risk factor. As you can see in this case that I placed the implant, it was restored with a resin cement, and what happens when we use resin cement and not using the copy abutment technique to cement. The 2 cements we're recommending is a temp bond or a zinc phosphate. So the zinc-based cements are what we're looking for. And also full arch implant restoration, as this patient above that has a generalized aggressive periodontitis who presented to me in 2006 at 49, smoker and a history of diabetes. And looking at the risk factor at this age, and she's presently 2018, she's 61. She's already lost an implant, and she's losing many other implants. We just treated her with a LePip procedure about a month ago. But again, age and her risk factors concern me, and the history of generalized aggressive periodontitis. So Will wants to know, how long will I keep my teeth? This is a great rationale to keep the lower teeth. You could see the amount of bone loss in the lower anteriors, but as PD mentioned, and all the long-term studies show that the lower incisors are going to be around there a long time. And they're one of the least ones affected with tooth loss over time. Especially ones that may be, even the ones that may have 50% or more bone loss. So as age increases, risk for implant complication leading to implant loss decreases. So our goal with Will is to move from here where he's younger to here where he's older. So maintaining those lower teeth as we can with Lenap. We got to his upper teeth too late, but he's asking now, we'd like to do implants in the upper. So the conclusions, and I want to thank my partner, Phil Fava, for some of these slides. We're going to maintain teeth when appropriate. The Lenap protocol really enables us to do that very quickly and really with infection reduction and elimination in the most prestigious and, as mentioned, the most fastidious way. We're going to try to delay implant placement in patients with a history of generalized aggressive periodontitis with multiple risk factors, again, reviewing the keys to success for the patient. And we want to treat them aggressively. And we use something called MyPerioPath on a basis where we could get to a targeted antibiotic based on their DNA profile of their of their bacteria subgingival. It's a rinse and spit, and it comes from my periopath.com. So the MMPPI with Will, he was kind of shocked that it was a 2. Jeff Thomas, a colleague and friend of both PD and myself, was in from North Carolina visiting, and he saw how we use the MMPPI and how motivating it was for Will to see, well, I don't need to lose, these lower teeth. Obviously, the root tips need to come out, but we can go ahead and treat these lower teeth. Again, we are clinicians, not magicians. Will now has a better understanding of his long-term prognosis. We gave him this target goal, encourages his lifestyle changes, which are in his hands. He's going to continue to quit smoking, improve his plaque control, and obviously go through treatment. So now he understands the importance of the LANAP. He understands the value, so he has gone through LANAP with the extractions, and he's going to adhere to the recommended maintenance frequency. Again, that was a big issue with him. So we went through the LANAP with the extractions. He still has some buccal caries that are being attending to now. Mentioned on the MMPPI, the 23 to 26 are guarded. We don't really need to note that, although in the patient's mind, we have the spaces there. We're planning with the restorative dentist, excellent local restorative dentist, Dr. White's, who placed an upper denture. We got a treatment plan together. We're considering molar uprighting on number 30, and either 3-unit bridge or a single implant in number 29 area. And he went from a 2 to a 0. So we round off to a 1, and he's got a 98% chance of keeping these lower teeth. Again, the keys to success are critical. We are going to consider also splitting the lower anteriors and do some cosmetic bonding at the same time. So he's been very compliant. He's proved to me that he's an excellent candidate for maxillary implants based on the keys to success. And this is most recent Panorex X-ray and clinical. So his plaque control is good, and he's ready to go ahead. So we got a CBCT taken, and we're planning based on his aggressive periodontitis. We want to go with a removable type of appliance for better plaque control versus an all-on-4 with tipped implants and a hybrid, so that he, as well as our hygiene team, has the best access for periodontal maintenance. Case number 4, another internet referral, lives about an hour away. He wants to keep his teeth. He had interviewed other dentists recently about treatment. He's another prior smoker. He's not on any medications, no illnesses, so he does not have the MIXs we're concerned about with a lot of our adult patients. He has parafunctional habits, and he has a generalized posterior aggressive periodontitis. And in his case, we're calling it occlusal periodontitis, which is a University of Pennsylvania term that we use a lot when we know there's a contributing factor of the occlusion with the ongoing periodontitis, making the periodontitis even more rapidly progressive. And as we look in the dotted red circle, number 3 is depressible. We're not using that. I'm concerned about tooth number 2 and number 3. We're going to use tooth number 30. 30 had a 1 mobility. You could see number 3 has a 3 mobility. This is the reason he came in, because he was uncomfortable in this area. He had very minimal overbite and overjet, so we really need to be cognizant of the importance of occlusal therapy in this case. We're basically taking number 3 just about or totally out of occlusion and letting the bone heal in that manner. And I call this molar disease because all the molars are affected, and we see this frequently with furcations and occlusal periodontitis. His initial score was an 8 using tooth number 30, and we could see why the probing depth was over 10. Diabetes, we didn't know his score, so we gave him a 2. His furcations, he had a buccal and a lingual furcation on number 30. Mobility was a 1, so a total of an 8. And as we know, when we're using the laser, there's tremendous penetration of about 3 millimeters, possibly more, in all vicinity into the bone, into the soft tissues, where we know a lot of the bacteria is being harbored. And these are the gram-negative bacteria that are really the black pigmented species that the laser is very specific for. My Perio Path enables us, in its oral DNA labs, enables us to more target the antibiotic therapy initially. So a case like his, we're most frequently using a combination of antibiotics similarly or something similar to amoxicillin with metronidazole. So we did full map LANAP with significant occlusal equilibration as noted. You could see the amount of bleeding post-hemostasis. Mike had a 2 out of 10 discomfort post-surgery. A lot of times the patients have more discomfort if there's an occlusal problem. So we need to be very attentive at that initial visit and at every subsequent visit that the teeth that are highly mobile, 2s and 3s, we need to really be very attentive to really get them out of occlusion if possible, or at least get them where there's no fremitus or reduction in mobility. So we do prophy plaque control review at each visit with one of my dental hygienists. Those are 1/2 hour visits. We do continued equilibration, occlusal equilibration. This is 2 months post-LANAP. And this is now, as part of our protocol, this is now our first periodontal maintenance at 3 months. Very minimal recession post-LANAP. It's interesting. Mike came to me because of the internet and Google and another service we use called Bird Eye. These reviews literally drives patients to our practice. We review the MMPPI at the initial visit. The patient understood the value of it, as you'll see in this review. So as stated by Mike, Dr. Levine explained to me in a manner that I would understand all of my options and also how he was able to determine the percentages of the chances I would lose some of my teeth, as it had to do with my habits, hereditary, and also if I was diabetic. We opted for LANAP surgery to get rid of my current infection and also help regenerate tissue. Again, I stress that the Millennium laser is the only laser out there that has FDA approval for regeneration. Pretty sure beforehand that I would lose some teeth no matter what, but would help the rest of my teeth. The surgery was performed on all 4 quadrants in 1 session. After several follow-up visits, Dr. Levine even surprised himself by saying that the surgery was very successful, and in fact, I haven't lost any teeth. I still have 1 tooth that is guarded. So far, so good after about 6 months. Very happy, driving an hour to go to his office for periodic checkups and cleanings, and he says, thank you very much. So we will be seeing him for his next periodontal maintenance in a month. So as PD had mentioned, the MMPPI and LANAP are mutually supportive like a hand in a glove. The MMPPI helps by translating the clinical outcomes, which in these cases that I'm presenting are the benefits of LANAP, into patient value, which is understanding case acceptance. And PD was a clinician for decades. And I love that he puts at the bottom, originally on the first MMPPI, if you have family or friends interested in saving their teeth, we welcome your referral. This is Mindy, who recently did a video for us as well on the procedure, the LANAP procedure and the MMPPI. And this is Mike, her husband. They were both patients of mine over 10 years prior, or approximately 10 years prior, and had not seen them since. Mindy was internet as well as self-referral. When she went to the internet, she saw my name and said, yeah, I remember seeing Bob years ago, because she felt that in the practice she was in, I've been very poorly treated, and I want my back gums to feel better, look better, because they constantly are bleeding when she flosses. So she's very compliant in what she does, but she was being undertreated. Her history, she's 55. Scaling and root planning was completed in my office prior, and she's been very compliant twice a year. So initially, her MMPPI was a 5. We scored tooth number 15. Her pain after LANAP was a 0 out of 10, and as she presented post-LANAP with maxillary frenectomy, which we routinely do as part of that as needed, and 3 months post-LANAP. She's thrilled with the results. The MMPPI went from a 5 to a 3, getting under that targeted score that we're looking for under a 5. Her initial furcations went from a 1, so meaning that she had 1 furcation, was on the distal of number 15, and went to no furcation that was unprobable after. Probing depth went to less than 5, so that was a 0. and the molar type we can't change. So it went from a 5 to a 3. So Mike is referred because his wife, Mindy, recommends that I come back to you to treat my gums. He's a registered nurse, 57, had scaling and root planing completed under our care over a decade ago. Good compliance like his wife, Mindy. But he presents with 6 medications to treat a number of ailments, and he presents with MIX. There's diabetes in the family, parafunctional habits, and multiple areas of mucogingival problems. So we point this out to the patient that I'm concerned with the MIX. These areas are more susceptible as he gets older for root caries. We know that. We see that a lot. And then restorative dentists frequently feel compelled not to treat the mucogingival issues, but place restorations, which invariably causes additional recession in some of these cases. And this is a Miller class 2 in the 29 area and a class 3 in 28, which is beyond the mucogingival junction with interproximal bone loss. We scored tooth number 2. Initially, he was a 7. He had a 1 mobility on tooth number 2. Again, discussing with him the benefits of the procedure, getting his mouth in health, and then with a second phase of treating his mucogingival problems. Similar to his wife, he went from a 7 to a 3. They were comparing their notes, and he's doing really well. Very, very happy with the results. His mouth is feeling much better, and you can see we still have 28, 29, and some other areas in his mouth that need to be treated for mucogingival issues, starting with the lower right, and that is our next phase with Mike. So, in conclusion, using the MMPPI for all our patients is a strong motivational effect. It increases acceptance, post-treatment compliance, and lifestyle changes. We translated clinical outcomes, which is the LANAP therapy, into patient value, which is case acceptance. We're now positioned as the physicians of the mouth, and we talk about that again on a regular daily basis. It takes only a few minutes to do. It empowers our whole office team, including our hygienists, our dental assistants. If they're the first one seeing the patient, they could get started with us, as well as our case presenters. In our office, my case presenters discuss this with the patients as part of a PowerPoint that I develop on each patient with all their clinical pictures that we take. Increases patient referrals, increases acceptance for their restorative therapy, and overall team-related compliance. And as you saw with Stephen's case, it plants the seed for future failure and retreatment. And what I really like, it increases our personal satisfaction as healthcare professionals. This is really something that has changed the way I've practiced, not only the LANAP, but melding it with the MMPPI, again, like a glove on a hand. And patients will write more 5-star Google reviews, as Michael did. And I want to note Dr. Miller provides free access to his web textbook, as noted, and I can't thank Dr. Miller and Millennium enough for allowing us to do this presentation together. And my good friend PD, I want you to close up for us here.
I think you'll find that this is going to be very motivational. And also keep in mind, you treat a 50-year-old patient, they have a score of a 5, and then 10 years later you score them again, they score a 5. Then they have that good a prognosis 15 years. Every time they're scored, it's 15 years beyond that. And that has a tendency, I think, Bob, to bind the patient to your practice and to share this information. And I think, as he says, we have a moral and ethical obligation to offer the patient the option of saving their teeth. And I think this encourages the patients to do that, and we become, again, periodontists. So those are my thoughts. Bob, thank you so much. Thank you to Millennium. And like I say, go to my website and get more in-depth information there. There's one on there, the most effective, least expensive mouthwash. There's another one on there, the importance of cleaning your tongue, because the bacteria that Bob mentioned on the posterior part of the tongue are sulfur-forming, and by cleaning the posterior part of the tongue, this goes a big way in preventing halitosis, bad breath, and all. So that's something else you can share with the patient. Anything else, Bob? If not, have a good day.